Hello, my name is Torra. I'm an adult nephrologist from Barcelona, and my field of interest is genetic kidney diseases. I'm going to share my thoughts and the review of the literature on assessing rapid progression in polycystic kidney disease. I would like to thank the PKD Foundation and PKDOC for inviting me. So you'll know how ADPKD progresses by increasing kidney size along with decreasing GFR. And we know that GFR only declines at late stages of the disease, while total kidney volume increases and is the main objective progression in the first period of the disease. So in fact, thanks to your advocacy and to the scientists, the FDI as well as the EMA accepted in 2015 the use of TKV in combination with age and EGFR as a prognostic biomarker. And that's especially useful for these early stages of the disease. And well, we've heard already some inputs about progression of polycystic kidney disease. When we compare its progression to those of acute nephropathies, such as all these immune nephropathies, of course, the first stages of the disease, the GFR remains normal, just like type 2 diabetes. But then when it starts to decline, it ends up declining pretty fast. And it's crystal clear there's a need for prediction of the disease. And this is based on the findings and the results and on the extrapolations from the results from the TEMPO and the REPRISE trial. We see how if we start early on in the course of the disease, like in the GFR of 90 at baseline, the magnitude of the effect is much, much larger than if we do that at late stages. So it doesn't mean it doesn't work, but the extent of the magnitude is much, much, shorter, smaller. So early intervention will obtain better outcomes, and there's a need to identify especially young rapid progressors. All these, we've seen that already in a way, are factors or objective tools to determine rapid progression. For example, we know that all these clinical factors in the left, like obesity, caffeine intake, high protein intake, low water intake, and smoking, will harm the kidneys and will enhance its deterioration. However, and also we know as clinicians that early onset hypertension, microscopic hematuria, or early increase in GFR are ominous signs of progression for PKD. But then we have a lot of other predictors, laboratory predictors, genetic and imaging, that will help us to decide whether a patient is a rapid progressor or it's not. And we'll go into detail reviewing those. I'm showing this slide that I know is complicated, but I like because it kind of reflects how the different situations and different aspects of the disease influence and interact between themselves. For example, the PKD protein levels and biological processes, age and cystic probability, it all interact and it changes a lot the weight of each of those. These are very good examples. For example, this patient 4 has a truncating PKD1 mutation that drives almost the full phenotype of that patient, being the environmental factors or other genetic, somatic events have much less impact than if we compare that to a patient 1, for example, that will be just the opposite. It's a patient with a PKD2 mutation, so a much milder disease that needs dialysis very late. So he has plenty of opportunities to being influenced by environmental factors, like the ones we mentioned, obesity, caffeine intake, hypertension, all those, and also other genetic factors involved. So, well, going back into why do we need assessing progression, it's because the FDA and the EMA, they both approved tolvaptan, you see with different names, generic, and it sounds exactly the same to me. But they approve generic for PKD, ADPKD patients, adults, in both cases, and both of them say for rapidly progressing patients, but they do not provide any explanation on what does this mean. And then what is rapid progression? So the working group of the ERA EDTA on genetic kidney diseases decided to consider a rapid progressor, that patient that would need kidney replacement therapy before the mean age that do ADPKD patients need kidney replacement therapy in Europe, which is 58 years. So if the prediction says that that single patient will need dialysis before 58, then this is a rapid progressor. In the US, the group from Mayo has recently provided some guidance and says that perhaps 50–75% of the overall ADPKD population could be considered rapid progression. And this increase from 50 to 75 is really an effort to include among the treated population more, I wouldn't say elderly, but older people than 58 that are still working and have lots of family obligations and so on. And in the same sense, in Spain, our consensus document increased that age by using the mean age of kidney replacement therapy in Spain for any disease, which is 65. So that increases a little bit the population to be considered rapid progressors. Then how do we assess rapid progression? How do we know if a patient will be or is a rapid progressor? And as I mentioned at the beginning, we need to do that as early as possible in order to have more effect on the with the treatment. So we assess rapid progression either with objective data or with prediction tools. With objective data is going back, retrospective data. So TKV growth, which is mostly unavailable, and retrospective GFR decline. And for prediction, we have imaging and biomarkers. So retrospective TKV would be quite theoretically a very good tool, but usually it's not available. And also there is a significant intra-individual variability because of rupture of cyst, and also the radiologist that performs the test may also have some variability when assessing the images. And regarding retrospective GFR decline, well, we know that varies a lot in CKD 1 and 2, which is the stage we would love to treat. And also, well, we know that eGFR remains stable for many years, as I showed before. So it won't be useful for early diagnosis of rapid progression, although as I show in this panel, it performs very well in relation with the Mayo class. Then I'm moving now to the prediction tools. And first of all, I will go through the imaging tools. And I apologize because I'm sure there will be radiologists in the audience and they will be much more experts than myself, but I'm going to do my best. So yeah, imaging predictors are extremely helpful for early prediction of progressing of ADPKD. And you all know that the CRISP Consortium made very, very nice observations and provided information on kidney growth, saying that it is exponential, its variable between patients is relatively constant, it is unique to each patient, it averages 5.3% per year. So the CRIS consortium showed a very nice correlation between the increase in total kidney volume and the decrease in GFR. And what is more important, this correlated very well, the baseline total kidney volume correlated very well with the outcomes in terms of GFR decline at 8 years. And of course, you all know, and it has already been mentioned, the Mayo class classification based on growth rates. And you all know there are 5 classes, and class E, D, and C are considered those rapid progressors with an increase of total kidney volume above 3%. And this is the extremely useful tool that we use on a daily basis, at least I do. And it is extremely convenient. The input is orthogonal dimensions, height, age, gender, race, and serum creatinine. And the output is mainly the most important one, I think, is Mayo class. It also gives some future eGFR approximations, but I would never advise to provide that to patients because as many of the tools I'm going to discuss, as a group, it works perfectly well for a cohort, but when we talk about individuals, it does not perform that well, probably. At least I tried with some and it was not that accurate. And it's a lot of pressure into the patient to say exactly you're going into dialysis or stage 3 in 3 years or 5 years or whatever. However, it's not it probably is the best tool, but it's not absolutely perfect. And for example, in this nice plot provided by Yorpay in the ASN, at the ASN in 2018, he showed us how some patients with high volumes had very good GFR, but this can be explained because they may be young. They still had no GFR decline, but on the other hand, we have patients with a poor GFR and a very and small kidneys, so I mean not too enlarged kidneys. So it shows that there are exceptions, and again, as a cohort, it works excellent, but in an individual basis, it's not perfect. It's probably the best we have, but not perfect. And another limitation of this tool is that it is not useful for a typical ADPKD. You all know what is typical, and atypical is anything which is not typical almost. And for all these situations, then the Mayo class is not useful. And I always say that some of these may not be slow progressors. I mean, most of them probably will, but some will not. And that is where the expertise of the radiologist, together with the common sense of the nephrologist, should join and decide on what's going on in that single patient and try to use our other tools to decide on progression. And what about measuring total kidney volume? There are different techniques. The planimetry is theoretically the gold standard, but it's labor intensive. It segments the kidneys. Then we have stereology, which is a very good approximation. It's relatively faster, but it does not provide segmentation. And finally, we have the ellipsoid formula. It is very fast. It's less precise. It does not, I mean, it's a good approximation. It does not provide segmentation. It has been shown that it performs very well compared to serology. So for daily practice and for deciding on rapid progression, I would consider that this is enough, and then it can be done in any center. And what do we have beyond total kidney volume? We have cyst count. Cyst count for adults sounds almost an impossible thing. But for kids or young adults with not so many cysts, it may be feasible, and it may be probably one of the tools to assess rapid progression very early on in the course of the disease. Of course, depending on the number of cysts, it may be difficult and very lengthy. And of course, it does not integrate downstream effects. And another option is texture analysis. And what does it comes from? Well, we have same kidney volume, but we may have different number of cysts, the cyst parenchyma surface, even cyst composition, and also the inflammatory fibrotic response among cysts. So texture analysis covers all that. It is an imaging processing technique that informs on the appearance, structure, and arrangement of different intensity levels within an image. These plots, nicely published by Klein and collaborators in 2017, show how well performs texture analysis compared to the traditional tools, traditional biomarkers for both CKDs 3A and 3B. And also, texture analysis provides an excellent prediction of GFR change when compared to traditional biomarkers. You see here in the right panel how the performance improves when we add texture. Then we move to ultrasound. Ultrasound is much cheaper than MRI for sure, and probably it won't be good enough for clinical trials, but it may be a first approach to select patients. For example, we know very well from the paper from Bhutani and collaborators that when the kidney diameter is less than 17, the accuracy of ultrasound measurements are pretty good. There are some drawbacks, of course. There's variability of measurement. It depends on how you, the diameter you exactly measure. It may change a little bit. It does not exclude a typical PKD, and it does not incorporate age. And to avoid that, not incorporating age, the working group of inherited kidney diseases of the era EDTA provided this criteria, which is that in a patient age less than 45 and a kidney length over 16.5, this patient assessed by ultrasound can be considered a likely rapid progressor. We analyzed that in a cohort of 178 patients that we tested everything in these patients, and we found that it is very sensitive and very specific when compared to the Mayo class, but it's very frequently unavailable. That means that, for example, in individuals younger than 48 with a kidney diameter of less than 16.5, you cannot use that tool for them because they may increase their kidney size and accomplish these criteria, but not for the moment. And same for patients older than 45 with a kidney diameter over 16.5. We do not know whether if that happened after 45 or before 45. So sensitive, specific, but not always available. And what about this using ultrasound for Mayo class? I know that will sound terrible to my friend Vicente Pinstores, but we tried, and we know that you can use the ellipsoid formula for the kidneys with ultrasound, of course, as well as MRI. There were some evidence that ultrasound compared to MRI performed pretty well for relatively small kidneys and not that well at all in terms of precision for large kidneys. So what we found is that the Mayo class performed very well for class for A, D, and E. So all those patients who were A were slow progressors, and all those who were D and E were rapid progressors. But it was not reliable for B and C. So although I acknowledge it's not a precise tool for clinical trials, it may be useful to select patients before an MRI. So you have a patient with a normal kidney diameter, kidney volume, or of Mayo class A. It doesn't make much sense to perform an MRI to assess that. So as a summary of imaging, total kidney volume is a very well-established tool for prognosis for more than 20 years now. It is very reliable, although I showed you how there are outliers. The Mayo class probably is the best single prediction tool we have nowadays. There are other non-TKV imaging markers that need to be assessed in real life in larger cohorts. And in terms of randomized clinical trials, US, as I mentioned, has low resolution, low precision, but maybe useful as first screening tool. CT, I believe, is not acceptable because of radiation, and MRI for sure is the gold standard. Then we move from imaging to laboratory testing. And in terms of biomarkers from laboratory predictors, we have urine biomarkers, which are very, very promising. For example, we have this nice work from the group from Groningen, from Rangensburg and collaborators. They use the urine to plasma urea ratio. They show how this is predictive of the concentrating capability of a patient with ADPKD. And it can be used as a surrogate marker of concentration capacity. So they showed how when this is below 3, it shows that it predicts slow progression, while when it is above 3, it predicts rapid progression. So this is much easier than water deprivation to test. And correcting for EGFR did not eliminate the association of the urine to plasma urea ratio with rate of kidney function decline. MCP1, I have to tell you that I first had to talk about it to my friend Ben Colley many years ago. He found and there was an increased expression of monocyte chemoattractant protein 1 within epithelial cells lining the cyst. Its concentrations are high in PKD patients, and increased amounts of urine MCP1 are most likely dependent on diminution of tubular reabsorption and secretion. The amount of MCP1 excreted in urine is related directly to serum creatinine, which may make us think, then what's the use of that? But MCP1 increases earlier than serum creatinine. So at a relatively early stage of the disease, the level of urinary MCP1 could be a reflection of the number of relatively small cysts that remain connected to the urinary collecting system. And you can see here, again, from the group from Groningen, how they show that MCP1 expression correlates pretty well with the annual decline of GFR. What about beta-2 microglobulin? Well, you know, it's a low molecular weight protein that forms the light chain component of class 1 HLA antigens. It comes from proximal tubular, so it's not unexpected, this finding, again from the Dutch group, that there is no correlation with kidney growth. We know that cysts appear all along the nephron, but they're mainly in the collecting dot and that part of the nephron. This is a very interesting and promising biomarker, which is a kind of signature using proteomics of PKD in urine. You can see how the aspect, and this is very complicated, the aspect of PKD differs significantly from controls. They found increased collagen-derived peptides, increased specific region of fibrinogen alpha, and decreased C-terminal fragments of uromodulin and osteopontin. So although this is far from clinical practice, and I wonder about reproducibility everywhere to assess progression, probably it is a very promising tool, and it's because it puts all together different proteins in urine and finding a signature for the disease and disease progression. And finally, these microvesicles, the exosomes in urine, seem also to be very promising in ADPKD. both in terms of therapeutic targets for the disease, but also as biomarkers, because the content of these vesicles is not modified by the GFR or by the protein excretion. So it's a promising tool that, of course, needs to be validated. I guess it will be very difficult to the reproducibility, but still is a promising tool. So these are my thoughts on urinary biomarkers. Freezing urine is a problem because it induces more variability for these biomarkers. Also, well, because ADPKD is a tubular disease with inflammatory component, measurement of urinary tubular damage and inflammation markers seems to be of interest, especially because these markers are relatively inexpensive, easy to measure, and not, and the reproducibility is acceptable, which is not the case for other biomarkers, as I mentioned, for example, this proteomic signature. What about the correlation of these biomarkers, urinary biomarkers, with TKV growth? Again, these and all biomarkers need to be tested in very large cohorts. Maybe they could be included as exploratory in randomized clinical trials to have a large population very well studied. And finally, the association of proteinuria complicates the analysis of urinary biomarkers. Although PKD is not a proteinuric disease, a certain amount may be there, especially at advanced stages. I'll move now to blood biomarkers. I already mentioned the retrospective GFR decline. In the algorithm from the working group of inherited kidney diseases of the EDTA, and also based on the KDIGO records, it defined rapid disease progression like this: more than 5 mLs per year, 1 year, or more than 2.5 in a period of 5 years. Although it makes sense from the teaching point of view, especially, we know that GFR remains very stable at early stages. It varies a lot, especially in CKD1 and 2, which this is, I would never use that. So it is not useful at early stages of the disease. And especially this one, 5 mLs 1 year, is very misleading because we tested that, and I think 90% of patients or even more experience that throughout their follow-up. This is an interesting biomarker, which is the soluble urokinase plasminogen activator receptor, the SUPR. It is a marker of inflammation, independent marker for incidence and progression of renal diseases. It has been shown to activate podocytes in glomerular diseases, but its performance has been hardly tested in non-glomerular diseases. And it has been in ADPKD, and the association between SUPR levels and TKV seems to be independent of age, sex, race, hypertension, and GFR. So these SUPR levels may be useful for early identification of patients with PKD at high risk of progression. We see here, you can see here how, according to the percentile, it correlates very well with the change of GFR. Copeptin is part of the vasopressin precursor hormone, the pre-pro vasopressin. It is in fact a surrogate marker of vasopressin, and its measurement is much easier than vasopressin. It has not so many technical constraints. It shows a positive association between total kidney volume and copeptin, and the baseline copeptin is associated with the rates of total kidney growth and GFR decline during follow-up. So it seems that copeptin is associated with disease progression and severity and could be used as a biomarker. Just a couple of thoughts on blood biomarkers. Most of them, most of the potential ones that will be studied also are hampered by renal clearance, making serum levels dependent on GFR. So this is very complicated. So they're promising, but they need to be tested as all of them in large cohorts and see how do they perform in clinical use. And what about genetic predictors? We know there's a significant intrafamilial variability. As the group from Toronto nicely showed, 12% of families show extreme phenotypic discordance. But if the families have more than 5 members that have gone into dialysis or transplantation, that increases to 30%. From the very beginning, I started working with PKD. This was something I realized, and I was very concerned about this. In fact, this is a very old publication, 1995, where we also expressed this concern. So all members from a single family share the same mutation. So the weight of the mutation, okay, it's considerable, but there must be many more things influencing the outcomes, because we see this quite important intrafamilial variability. And this would be just the opposite. Seeing how good is the genotype-phenotype correlation. And of course, this is the very nice work by the group from Brest, led by Emily Cornet-Legal. And she showed very nicely how truncating mutations confer a very bad prognosis compared to missense mutations or PKD2 mutations. So again, it works extremely well in cohorts. But and they also provided the ProPKD score, which includes some clinical features, and this is somehow an effort to improve the performance of the genotype-phenotype correlation, to explain, to avoid this unexplained variability within a family. So being a male, hypertension before 35 years of age, urological event are adding points to the genotype. So if it is over 6, the patient is considered to be likely a rapid progressor. But many patients with truncating PKD1 mutations do not show early symptoms. But not only this, but also symptoms must be really related to PKD. For example, at 20 years old with like 3 cysts in each kidney and a stone passing blood, then yeah, it's microscopic hematuria, but also you have to use your common sense. It is not an advanced disease, it's just a stone there. So very careful when attributing these urological events to PKD. So theoretically, there is a correlation between genotype and the severity of the mutation to the kidney size and Mayo class. But there are many outliers in real life, and this is in line with what we see with intrafamilial variability. For example, again, this nice work from the Toronto group, they showed how 18% of patients with truncating PKD1 mutations have mild disease. Also, this one, second work from Heyer, showed how there are PKD1 patients that do very well and PKD2 patients that need dialysis or transplantation quite early in the course of the disease. And our own results showed how ProPKD has a high specificity but low sensitivity, mainly because most of the rapid progressors do not show any clinical signs before 35. So this is probably the main reason why the sensitivity is low. And also, again, showed by York at the ASN in 2018, he showed how some patients with low-risk mutation class have high risk at Mayo class, and the opposite to that, patients with high risk mutation have a low risk Mayo class. What about using family history for prediction? I find it, to be honest, in real life, very helpful. So if I have a patient that tells me that all the family has gone into dialysis quite young, I think that patient is or will be a rapid progressor. So when relatives go into dialysis before 50 years of age, that's highly predictive of rapid progression. But there is still, as I mentioned, a high intrafamilial variability. So with this alone, we will never say for sure this is a rapid progressor. There are many discordances, and we need to assess it with other tools. But again, that could be something to ultrasound. There are very easy tools, very simple, very cheap, that may guide us to decide whether that single patient deserves any further examinations to assess rapid progression. So some thoughts on genetic predictors. They perform better in cohorts at individual level. I would never recommend to determine progression based only on genotype. I would love to see one day a composite predictor tool containing the mutation in it. And finally, family history may suggest rapid progression, but won't be never enough to determine rapid progression by itself. And finally, I will point to some algorithms or some decisions on rapid progression. This is the European algorithm, which, as Jörg again showed nicely, it excludes a lot of rapid progressors. We also tested that in a large cohort of 300 patients, and we saw how it performs pretty well in younger than 30, but this is because there are no exclusion criteria for this range of age. The exclusion criteria begin at 31 years of age. So from 31 to 40, they have to have a GFR below 90, and from 40 to 50 below 60. So this restriction of GFR is what makes the use of this algorithm very imprecise and leaves behind a lot of rapid progressors, especially in these age ranges. For example, these are the patients we analyze, and the ones within the green line are the ones that fulfill the criteria to be assessed for rapid progression. But all those here, many of these had Mayo class C, D, and E, but were not assessed because they did not fulfill the criteria for age and GFR. So we clearly think that the algorithm is outdated, and a new one will be provided soon, hopefully. To my understanding, this is what is being done at the US, mainly using the Mayo class, which, as I mentioned, I think is the best tool to use as a single tool, and they advise to treat patients with a GFR over 25. And finally, this is our Spanish consensus document. What we use, as I mentioned, was 65 as the mean age before those who are predicted to reach end-stage kidney disease before 65 were going to be treated and assessed for rapid progression and treated. And yeah, we recommend treating all those above 30 mL GFR of 30 and individualized from 15 to 30, and from 55 to 60 to have a GFR below 60. And for assessing rapid progression, for Mayo class D and E, we all reached consensus. And for class C, it's not that we don't think they're not rapid progressors, but because in Spain is covered by the public health system, all drugs, they kind of restrict, and we agreed that some certain amount of 1C patients are not that rapid progressors. And so if we could demonstrate a GFR decline more than 3.5 years per year during more than 3 years of family history of end-stage kidney disease before 58, that will confirm the rapid progression. And we recommend always to perform an MRI before starting treatment. This is an overview of the randomized clinical trials. You'll know Untitled using total kidney volume and GFR as primary endpoint. The PREDICTORS trial uses GFR. There's not expected to, well, I mean, you know the mechanism of action, so GFR is the output, the endpoint. Lixivaptan, well, they're using GFR. Benglostat is using increase of total kidney volume. Same for Galapagos and Tevasitinib, and these two are phase 2, so quite exploratory. And finally, Regulus, this is a phase 1, and I wouldn't, I mean, the endpoint is for phase 1, it's not clinical endpoint. And finally, these are my take-home messages. The risk assessment in ADPKD is an evolving process to be redefined by new clinical data and test technologies. There is large dispersion in the rate of disease progression between patients in the same risk group, and there are overlap between groups, and this is a big concern for individual prediction. Currently, the Mayo Clinic Imaging Classification likely provides the single best risk assessment tool. The EVA-EDTA working group algorithm is outdated. Gene-based testing is less reliable at the level of individual patients than in cohorts. And the performance of risk assessment tools needs to be evaluated and validated by real-life clinical data. Maybe a composite tool will be what we will end by using. So thanks very much for your attention, and I'll be very happy to discuss with all of you.